Good morning. My name is Roshni Patel. I'm going to present the deaths secondary to hemorrhage and AFE from this latest report. In addition, the report includes a study on early morbidity following repeat caesarean section. There are clear and common themes across all of these groups, which I hope to share. Obstetric hemorrhage remains a common feature of maternity care. Fortunately, in the UK, maternal mortality secondary to hemorrhage remains rare. In this latest report, there were 18 deaths secondary to hemorrhage, of which 17 were early deaths, and one was a late death, which occurred after 6 weeks following an earlier placental abruption. This gives a rate of 0.8 deaths per 100,000 maternities and represents a non-statistically significant increase from the previous report of 0.76 per 100,000 maternities. There are increasing numbers of severe morbidity cases secondary to PPH, and with a section rate of over 30%, it will potentially remain a feature of both severe morbidity and mortality, particularly with the increased numbers of cases associated with placenta accreta spectrum. Looking at the data for amniotic fluid embolism, there were 8 early direct deaths secondary to AFE, which is equivalent to 0.36 deaths per 100,000 maternities. Of the 8 deaths, 6 occurred on the day of delivery, and the 2 further deaths occurred within 3 days of delivery. So overall, the maternal mortality associated with AFE remains unchanged. The previously identified in MBRRACE reports were observed causes of hemorrhage and AFE. Not all recommendations from previous reports were followed in these particular cases. For example, the recognition of the clinical signs of significant blood loss, delays in treatment associated with systems under pressure, and the need for additional awareness situationally and senior leadership. The selection of vignettes illustrates the key messages that I'm going to present, but additional vignettes in the published report reinforce the themes further. This is slightly long to read, but an important case, and I'll give you a moment to look at that. Assessors felt the woman was unlikely to have a vaginal birth following her admission with prolonged rupture of membranes, preeclampsia, meconium, a raised BMI, and suspected sepsis, and that a caesarean birth should have been offered earlier in the day. The risk factors of PPH were evident from the outset, and PPH could have been predicted at the time she underwent caesarean section. But 2 significant problems then occurred. There were repeated attempts to insert a Bacri balloon, even when this was not succeeding. The impression from reading the case was that the clinicians were reluctant to return to theatre. This was somewhat understandable in a woman with a very high BMI, but nevertheless, as the PPH was not controlled, further steps needed to be taken. The problem was then compounded as although 5 litres of blood had been lost, she was then denied blood clotting factors as the haematologist relied on the bedside coagulation tests. Therefore, a new recommendation is the urgent need to produce guidance on the use of bedside tests for the assessment of coagulation, along with the required training to undertake and interpret those tests. In the absence of hemostatic bedside tests, which are not available in all units, the early use of fresh frozen plasma should be considered for conditions with suspected and these would obviously include AFE, placental abruption, and in cases where the diagnosis of PPH has been delayed. There is also new guidance to remind clinicians on when to use tamponade balloons and when to move on to new methods. It is in these cases where PPH management proformas, including a helicopter view from a senior clinician, are both helpful in guiding care. I'll give you a moment to read this vignette. This case, the inappropriate, excessive, and prolonged use of vasopressors, which was a pattern seen across several cases. Firstly, we are reminded of previous recommendations. The response to obstetric hemorrhage should be tailored to the proportionate blood loss as a percentage of circulating blood volume based on a woman's body weight. Weighing women for their VTE assessment is part of national guidance. It's also very useful in this context. All fluids should be warmed and not at room temperature, or certainly not at fridge temperature. In the context of hypervolemia, it is crucial to remember that the prolonged use of vasopressors infusions to maintain the blood pressure prior to or instead of replacing circulating volume can compromise organ perfusion. It can also worsen acidosis. We know from trauma care it is well recognised that the association between hypothermia and coagulopathy leads to the so-called lethal triad and is a high risk of mortality. Thus, similarly, high volume resuscitation with crystalloids and colloids is associated with coagulopathy and adverse maternal outcomes in women with PPH. It is therefore imperative to recognise deterioration in any of these key parameters when managing massive obstetric hemorrhage. Cases of placenta accreta spectrum are rising, and there is national guidance already in place on the location and care of these women. Case. And I'll give you a longer moment to read this case. Good. These two cases I've just shown illustrate the need for women with known placenta accreta spectrum disorders to be treated by multidisciplinary care teams with expertise in complex pelvic surgery. Care should be in a specialist centre with logistic support for immediate access to blood products and both adult and neonatal intensive care units. It is also really important that midwives and obstetricians make women who are seeking multiple, by which you mean 3 or more, future pregnancies after a primary caesarean section, that they're counselled about opting for elective repeat caesarean section may expose themselves to greater surgical risks. Some of these described deaths and morbidity cases, which I'll talk about later, also brought to the forefront the need to manage workload, which was a theme replicated over many cases and sadly familiar to many staff working in current maternity services. Do read this case. The further detail on this case and local investigation revealed a desire to complete Category 4 caesarean sections during the daytime so that elective cases would not be cancelled and allowed emergency cases to occur out of hours. A new recommendation advises that Category 4 caesarean section lists are managed separately for more urgent caesarean sections to ensure these operations are not delayed to late in the day. This case exemplifies a system under pressure. It is crucial, therefore, that all units have escalation policies for periods of high activity. Equally important is that this encompasses senior multidisciplinary support and, if necessary, closing a unit and diverting activity. Next, I wanted to share an overview of the early morbidity cases after repeat caesarean section, which is featured in the current report. The caesarean section rate between 2019 and 2021 was 31%, which includes elective and emergency procedures, and this will inevitably be associated with the potential for operative complications and morbidity. In the UCOS study, there were access to 32 sets of notes. Two-thirds had one previous caesarean section, and the remainder had two or more. In this group, approximately half had a re-laparotomy due to bleeding. Surgical bleeding. One was associated with a rebleed from PAS, one from uterine atony, and two from abdominal wall incision bleeding. This is one example. I'll give you a moment to read the case. This case illustrates a reluctance to acknowledge that there was ongoing bleeding. The hemoglobin was dropping, and there was even the benefit of seeing fresh blood in the drain. The patient could have gone back to theatre almost 12 hours before she did return. Now, in this case, fortunately, the patient went on to make a full recovery. This is another case that similarly highlights a delay in review. I'll let you quickly review this. The midwifery team clearly recognised and their requests for a review were not actioned. Whilst this woman and the woman in the previous case both recovered, I think these should be regarded as near misses and could have sadly ended in a much worse outcome. An important new recommendation is the recognition there is often valuable learning from cases that return to theatre. But it should not be perceived as a performance metric after caesarean birth, as reoperation may be the most appropriate response to control internal hemorrhage. In the review of these 32 cases, 72% of them showed that there were improvements in care identified that could have made a difference to the outcome, which clearly shows us that there are still messages which need to be learnt. In summary of the key themes in this report regarding the management of haemorrhage, whilst obstetric haemorrhage can occur unpredictably, this report has reminded us that many cases can be anticipated. The antenatal diagnosis of placenta accreta spectrum placenta with a previous caesarean section. Women planning large families need to be counselled about the risk of repeat multiple caesarean section. The care of these women needs to be individualised to the correct location and senior multidisciplinary team. The early recognition and therefore response to severe PPH is fundamental to avoid further deterioration and the development of coagulopathy. And this is facilitated with early MOH calls and having protocols in place and the inclusion of a scribe and a senior clinician taking a helicopter view. And in these cases of severe PPH, there is a need for senior MDT involvement. The signs of bleeding need action, even when concealed. Thus, in the absence of classic signs of hypovolemia, including tachycardia, hypertension, falling saturation, there needs to be resuscitation and an earlier return to theatre. Having drills and training simulation courses will aid these processes, and policies in place regard to heavy workload, but also managing category 3 cases. Thank you very much.